Hi everyone! Thank you so much for coming to my dreams presentation. My name is Annie Tao, and I'm currently a junior double majoring in molecular and cellular biology, as well as public health. I've been working at the Sumner Lab for almost a year and a half, working on this project called Analysis of Pathological Outcomes from Nusinersen Treatment on Patients with Spinal Muscular Atrophy. So first, some background information. Spinal muscular atrophy, or SMA, is an autosomal recessive motor neuron disease with an incidence of approximately 1 per 10,000 people and carrier frequency of 1 in 40. It's the leading inherited cause of infant and childhood mortality around the world and is a motor neuron dysfunction and loss which causes profound muscle weakness and atrophy. As you can see in the adjacent image, the SMA motor neuron is significantly smaller and looks more shriveled than the healthy one, with a weaker axon leading to the muscle, which atrophies since it can't respond to signals from the nerves. There are two nearly identical SMN genes, and SMA occurs when there's loss of function in the survival motor neuron 1 gene. The disease severity varies with the transcription of SMN2, which produces a truncated protein. The more SMN2 copies there are, the less severe the symptoms. There are 3 types of SMA, each with different levels of severity and times of onset. In the picture, it's evident how type 3 can still walk and stand and looks to be in much better condition than the other 2 types, particularly the baby in type 1, who can't even sit up. There currently are several therapeutics targeting the genetics of SMA. The first is a gene therapy system which seeks to replace the SMN1 gene using an AAV virus as a delivery system. Then there's nusinersen, which is an antisense oligonucleotide which acts as a splice modifier which targets intron 7 on the SMN2 gene to promote inclusion of exon 7, which typically is spliced out so that there will be more full-length SMA protein. Small molecules like branaplam, which is approved in 2020, also promote exon 7 inclusion but aren't sequence specific. My project is focused on studying nusinersen to determine the pathological outcomes in patients. There's been shown to be a spectrum of efficacy following nusinersen treatment. Although it's still effective in some patients when given post-symptomatically, the earlier it's administered, the better, since there will be more SMN2 to start with. There also is a variable response by different body segments where appendicular motor units may improve more than axial ones. There are 2 outcome measures to determine efficacy: behavioral/clinical, like whether or not patients are walking or their muscles are atrophying, and pathological, which involves studying the motor units, which is the focus of our project. We compared the neuromuscular junctions, proximal motor axons, and motor neurons in treated SMA cases to controls and treated cases. This is a table with details of the autopsied cases who received nusinersen, from which the lab collected samples. Nusinersen is administered intrathecally since it can't penetrate the blood-brain barrier and goes through the cerebral spinal fluid to the motor neurons. The closer the delivery to the lumbar region, the more antisense oligonucleotide and the better the response. PMI stands for post-mortem interval, which is how long after the patient passed away and samples were collected. Duration is the time from diagnosis until death. Most of the cases had 2 copies of SMN, so they are SMA type 1, except the last one, which is type 2. These are images used to measure pathological outcomes of the cases from the earlier slide, in which we sought to determine a correlation between how the patient responded to treatment and the pathology. There was lots of variation in outcome. Some recovered normally, while some still had to use a wheelchair, and this was dependent on when treatment started, how many SMN2 copies they had, as well as the dosage. SMI32, the green, is a marker for neurofilaments and axons. As you can see, the longer the treatment, the better innervated the neuromuscular junctions were. This is an image of a proximal ventral root in untreated controls, treated SMA cases, and antisense oligonucleotide treated SMAs. As you can see, the control looks healthy while the treated one resembles the control more than the untreated, which looks very shriveled. Analysis of the images show that ASO treatment didn't improve the size or myelinated axon number in type 1, and type 2 has better improvement because they start with more SMN2. These electron microscopy images are examples of axons from the controls, untreated, and treated cases. As you can see, the leftmost image is what a healthy axon looks like, with a thick myelin sheath, while the untreated SMA looks very unhealthy with not much myelin, and the two untreated ones have some improvement in myelination, but still very small axons. The diagram on the right is a measurement of G ratios, which is a ratio between the inner and outer diameters of the myelin. We are still currently in the process of quantifying G ratios. The diagram on the left shows that untreated SMAs have more unmyelinated axons, while some of the treated SMA cases, such as the last one, were restored to a similar proportion like the controls because they have an increased percentage of myelinated ones and reduced unmyelinated proportions. However, other cases didn't display as similar outcomes, possibly because they weren't treated for as long. These are images of motor neurons in the lumbar spinal cord of a control, untreated SMA, and nusinersen treated SMA patient. CHAT, which is a cholinesterase transferase, is a cholinergic neuron marker and is shown in red. The green is SMI 312 again, showing the axons. Although there aren't quantifications for this yet, these images look very promising because 1901 resembles the control and looks very healthy, with more synapses and vigorous processes. The conclusions of this study are as follows. Response to nusinersen treatment in SMA patients is largely influenced by many factors such as SMN2 copy numbers, disease severity and age at the start of treatment, dosage, and treatment duration. Preliminary analysis from the ventral roots and neuromuscular junctions in the vulnerable muscle groups of untreated SMA type 1 and type 2 patients and nusinersen treated SMA type 1 and type 2 patients indicate improvement in pathological outcomes, which correlate positively with earlier and longer installation of nusinersen treatment and SMN2 copy numbers. Further biochemical analysis on increase of full-length SMN2 expression at the mRNA and protein level as well as penetration of nusinersen needs to be conducted. Even patients with a better response often still die of cardiac arrest or infectious disease, indicating that more combinatory treatment targeting the peripheral organs and immune systems may need to be installed together with intrathecal delivery of nusinersen. This project would not have been possible without the guidance and mentorship of the lab's principal investigator, Dr. Charlotte Sumner. Thank you for coming to my presentation. I hope you enjoyed.